Dear colleagues, a warm welcome to the third OncoAlert Colloquium, this year being held in partnership with the American Society for Radiation Oncology, the European Cancer Organization, the European Society for Gynecological Oncology, the European Oncology Nursing Society, the European School of Oncology, eCancer, the International Society for Geriatric Oncology, the Multinational Association of Supportive Care in Cancer, and the SWAL Cancer Research Network. Together, we bring you this end-of-the-year review of the Best of Oncology 2022, from trials to publications, drug approvals to current controversies within our field and future trends in treatment and research. This colloquium will last 6 days from January 23rd to January 28th, 2023. Links will appear on social media, and you can always find them via our website, OncoAlert360.com, and there you can find the colloquium webpage. You will find the possibility to subscribe to our newsletter, and we will send you the links daily. This colloquium is independent of any financial support and comes to you as a result of our partners and our faculty working hard in order to drive the field forward, regardless of geography. There is no sign-up, no information acquired or tracked. You simply click and watch. We truly hope that you enjoy this colloquium as much as we enjoyed making it. All the presenters have added their Twitter accounts at the bottom, and this was done in order to facilitate networking, contacting, and education. The days are separated by specific tumor groups, and our aim was to give you as much of a multidisciplinary approach as possible. Although we apologize to our surgery colleagues, we promise to have this included for our fourth colloquium. The daily links to the colloquium will be active at 12 noon EST, New York time, and 6 p.m. CET, Stockholm time. Once the presentation has been streamed for the day, it will be available to you on demand, and we highly encourage you and thank you for sharing it with all your colleagues at your institution to truly amplify the knowledge coming out of our faculty. Another way of receiving the links daily is always by signing up to our newsletter at www.oncoalert360.com. Today is day 5 of the colloquium, focusing on the best of GI oncology in 2022 and finishing off with a SIOG session in geriatric assessment. We're joined today by an amazing faculty, Dr. Cathy of Vanderbilt University, USA, covering colorectal and anal cancer, Dr. Sharlene Gill of GI Cancer Vancouver, Canada, covering gastric and esophageal cancer, Dr. Mark Lewis of Intermountain Health, USA, covering pancreatic cancer, Ms. Allison Rosen of American Cancer Society, on the patient perspective in GI cancers, and Dr. Nina Sanford of UT Southwestern, USA, presenting in the best of GI Cancer Radiotherapy. Dr. Hongcheng Zhu of Fundan University Shanghai Center, China, presenting on ESO session on health-related quality of life and esophageal cancer. And finishing with Dr. Grant Williams of the University of Alabama, USA, for a SIOG session, integrating geriatric assessment. Now, without further ado, Dr. Ang.
It is my sincere pleasure to speak on behalf of the OncoAlert Colloquium regarding year in review for colorectal and anal carcinoma. My name is Dr. Cathy Ng, and I'm from Vanderbilt Ingram Cancer Center here in Nashville, Tennessee. I want to remind individuals what's the expected incidence of colorectal cancer as well as anal carcinoma over the next 20 years. And as you can see, based upon this analysis from GlobalCan, it is still going to be a continued area of concern for both colon, rectal, and anal carcinoma globally. So what are our options for our patients diagnosed with colon cancer, rectal cancer, and anal cancer? Well, I want to remind individuals there is an ongoing trial specifically focused on the role of circulating tumor DNA for stage 2 patients. As most of you are aware, for stage 2 colon cancer, it's often a matter of discussion. But here, the COBRA trial offers us the opportunity to enroll patients to this national trial and to utilize circulating tumor DNA as a possible approach for treatment decision making. So the patients will be randomized to either standard surveillance, where the circulating tumor DNA is batched, or they'll be randomized to assay-directed therapy. And if the patient has positive circulating tumor DNA, then they would be recommended to receive adjuvant chemotherapy for these stage 2 patients. This trial is enrolling well, and we would encourage you to continue to enroll on this clinical trial. For stage 3 patients, we have the Circulate US trial, which has just recently been opened as well. And this, as you can see here, is specifically for stage 3 patients. And patients are either based upon their circulating tumor DNA status. If there's no DNA detected, circulating tumor DNA detected, they will proceed with standard adjuvant therapy or basically no treatment. And if circulating tumor DNA is detected early on, then they will be randomized to either standard adjuvant to FOLFOX or CAPOX, or in this setting, FOLFOX-ERI. And so this is currently open to enrollment. We would encourage individuals, once again, if you have a stage 3 patient, please consider enrolling to this clinical trial. What about an MSI high rectal carcinoma? I know this is a very small proportion of our patient population, but many of you have already seen the data with looking at immune checkpoint inhibition with dostarlimab in a single institution analysis from Memorial Sloan Kettering Cancer Center, in which patients received 6 months of therapy. And because of their benefit of response that was noted, if they had excellent benefit clinical response, they were not then randomized or subjected to any radiation therapy or surgical resection unless there was evidence of residual disease. This was a pilot trial of originally 30 patients. And as you can see here, the majority of patients were T3 or T4 and node positive patients. Not all patients were Lynch patients, but they were all BRAF wild type V600E patients. And what was impressive, obviously, with a median follow-up of only 6 months thus far, and obviously we need more data, and we would like to validate this data in other institutions as well, is that these patients did have 100% clinical complete response at this median follow-up of 6 months. And this is the waterfall plot. Now, you should be aware that there is an ongoing national trial of nivolumab plus ipilimumab with the consideration of short course radiation therapy if there's any suggestion of necessity of receiving radiation treatment. This trial is undergoing an amendment at this time, and it's going to look at the duration, a shorter duration of approximately 4 months of combined immune checkpoint inhibition to determine if we can have the same degree of response. And so hopefully we can also avoid radiation therapy as well as consider organ preservation with sphincter preservation, very similar to the Memorial Sloan Kettering data. But once again, this does allow access nationally for all patients because this is a trial that is ongoing. Currently, we're still waiting for the results of the Prospect trial. Many of you may have recalled that this completed enrollment several years ago. We are waiting for these results to be presented and basically hoping to omit the role of radiation therapy for mid to high line tumors, depending upon the degree of response to new adjuvant therapy. Now, currently, the OPRA trial was just recently published in JCO, and basically it looked at the sequence of therapy, whether or not you received induction chemoradiation therapy followed by consolidative consolidative chemotherapy, or whether or not you received induction chemotherapy followed by consolidative chemoradiation therapy. This was a phase 2 study completed at select sites that was initiated by the Memorial Sloan Kettering Cancer Group. And basically the primary endpoint here was disease-free survival. And based upon whether or not you had a clinical complete response or a near clinical complete response, there was the consideration of whether or not the patient could have a watch and wait approach and defer TME as long as possible until there was full evidence of disease recurrence or progression. And this is basically the results that were originally presented at ASCO 2021, and that's now since been published in JCO. And you can see here, there was no difference in disease-free survival or local recurrence-free survival, regardless of which approach in regards to sequence of therapy that you provided to the patient. But what was noted was that if you provided concurrent chemoradiation therapy first, followed by consolidative chemotherapy, these patients fared better for the consideration of sphincter preservation. And obviously, if you have young patients or patients that are not optimal candidates or do not want to have any potential of a colostomy, this is obviously an intriguing option for these patients. And as a result, This is now resulting in a large phase 2 study of 312 patients as led by Josh Smith and Arvind Desari and Bill Hall, as well as others, looking at the role of chemoradiation therapy first, followed by consolidative chemotherapy with either FOLFOX or FOLFIRINOX, and the primary endpoint is clinical complete response. And as mentioned earlier, this trial just recently opened. What about options for our metastatic colorectal carcinoma patients? So you should be aware that we do have some data that has been updated, specifically prospective data, looking at left-sided treatment-naive metastatic colorectal carcinoma patients. These patients we know do much better if you have a left-sided tumor than a right-sided tumor. And you should only consider anti-EGFR therapy or anti-VEGF therapy in left-sided tumors. We now know you should never provide anti-EGFR therapy to a right-sided tumor in a newly diagnosed metastatic patient. So this is the paradigm trials led by Dr. Yoshino. The primary endpoint was overall survival. And although the primary endpoint was met, and I do want to point out one thing that's I think it's extremely important to point out here is about 60% plus of the patients that had their primary tumor resected in this patient population. This is not required. We now know that based upon the synchronous trial that you do not need to resect the primary tumor for benefit of response for survival, as long as there's obviously no impending obstruction or perforation. But here's the primary endpoint of overall survival for left-sided all RAS wild type tumors with a hazard ratio of 0.82, suggesting that you should provide anti-EGFR therapy or could provide anti-EGFR therapy in combination with FOLFOX to improve the overall survival of patients. It should be noted the disease-free survival was no difference between the two arms. The response rate did appear to be slightly greater, as you can see here, of 80% versus FOLFOX plus bevacizumab at 69%. And the change in depth of response was also more noticeable in the panitumumab arm. What other new options have we learned of as of late? Well, we did have the presentation at ESMO, where I had the honor to help lead this trial with Arvind Desari, looking at an orally available, very selective tyrosine kinase inhibitor of VEGF receptors 1, 2, and 3 in patients that were heavily pretreated. And it does not mean that the patients had to be heavily pretreated. It's just that we allowed the patients to have had multiple lines of therapy because we want to provide a new option for these patients, which was an unmet need. This is a 2-to-1 randomization versus placebo plus best supportive care. And fruquintinib is given 5 milligrams daily for 3 weeks on, 1 week off. This is the patient population here. This was truly an international trial involving Asia, Europe, and North America. The median lines of prior therapy was 5. The majority of patients, greater than 50%, had had at least prior Lonsurf. Only a small percentage had received just regorafenib alone. The majority otherwise had received the combination of both. Primary endpoint was overall survival. This is the forest plot regarding the patient population, which for the large part is all in favor of fruquintinib. And here is the primary endpoint. So in these patients, there was a difference of 2.6 months in regards to overall survival with a hazard ratio of 0.662. So a 34% increased likelihood of survival if you receive fruquintinib versus best supportive care. And in addition to that, the progression-free survival was also positive at 1.9 months with a hazard ratio of 0.321. So this drug overall was tolerated well. There was a class effect, as you can guess, for any anti-VEGF agent, which is hypertension. There were instances of asthenia and as well as hand-foot syndrome, but that was in less than 8% of the patient population, but overall tolerated extremely well. This manuscript has been submitted for publication, and this also application has been submitted to the FDA. What other updates do we have? We know that there's increased precision oncology for our patients, and basically we are now learning that KRAS G12C is not a common finding in our colorectal cancer patient population, but there is data to support its use for colorectal carcinoma patients. This is sotorasib, which has been evaluated in a phase 1 originally, and then a phase 2 expanded cohort study in addition with panitumumab. Many of you know it's already approved for lung carcinoma, or being evaluated for lung carcinoma, sorry. Here we show the response rate is about 30% in this small patient population. And as you can see, there's a significant degree of tumor response, and duration of treatment was very favorable. I just want to show you that there are 3 ongoing trials, phase 3 sotorasib in combination with panitumumab. Once again, this is G12C. And then there's the Lilly trial as well. That is a phase 1 trial, and then there's the Mirati phase 3 trial that is also ongoing with adagrasib and cetuximab. So please enroll to these clinical trials if possible. What about our BRAF patient population? Well, we now know still that these are poor prognostic patients. We know the doublet of encorafenib and cetuximab is the standard of care, and when it's moved up to the frontline setting, that still was not sufficient to provide improved progression-free survival for this patient. So it's really no different from the previously treated patient versus the frontline treated patient population. So we need to find new options. So Van Morris from MD Anderson Cancer Center presented this data in combination with nivolumab because there appears to be some encouraging activity. And basically in their single institution analysis, they noted an improvement of response about 50%, but more importantly, progression-free survival of 7.4 months and median overall survival of 15.1 months. So as a result, this trial is now a national trial called SWOG 2107, which will allow 1 to 2 prior lines of therapy. It's a 2-to-1 randomization, and they hope to enroll 75 patients. This trial is currently ongoing, so please enroll for previously treated BRAF mutant V600E patients. There is an ongoing phase 3 trial called Breakwater, and you should be aware that basically it is looking at the role of systemic chemotherapy in newly diagnosed BRAF V600E patients in combination with a doublet. What about HER2? I wanted to mention this. Everybody's kind of seen this Mountaineer data, which is looking at the role of tucatinib and trastuzumab in patients that have received prior chemotherapy. Once again, we encourage these to be patients that are 2+ by FISH or 3+ by IHC. And in this setting, we noticed that the combination resulted in a significant reduction in tumor burden. And this is a very small patient population that are going to be HER2 positive, usually less than 5% of our patients. But once again, very encouraging data, as you can see in regards to response. And in regards to PFS, 8.2 months and OS 24.1 months. And as a result of this trial, tucatinib just got FDA approved just a couple of days ago on the 19th. So very encouraging. And once again, it reminds our providers to please test for HER2. There is a Mountaineer 3 trial, which is opened or is due to open shortly in combination, investigating the combination with FOLFOX in this setting as well. So please enroll to that trial if you have it available for your patients. What other trials are we waiting for? Well, we had already learned of the phase 2 data of LONSURF or TAS-102 in combination with bevacizumab in a smaller analysis of less than 100 patients, encouraging overall survival data of 9.9 months versus 6.0 months, but that data needed to be validated. As a result, the SUNLIGHT trial was completed, and basically the SUNLIGHT trial is looking at patients that have received at least 2 prior lines of therapy, and if appropriate, RAS wild type may have received anti-EGFR therapy. And here the primary endpoint is overall survival. This was a trial largely conducted in Europe looking at trifluoridine and tiprocel, or TAS-102 plus bevacizumab versus TAS-102 alone. Once again, here are the results that were just reported out today of 10.8 months versus 7.5 months. About a quarter of the patients did not receive prior bevacizumab with their first or second line therapy, so that would be quite interesting to evaluate further. But in this analysis of these 400+ patients, they noted an improvement of 3.3 months in regards to overall survival. Now we're still waiting for the data of lenvatinib and pembrolizumab, which is finished enrollment and hopefully will be reported out soon. So please keep your eyes out on that. For our other metastatic patients, we do have other new trials that have just opened or about to open. This is ERASER, which is looking at the role of either stereotactic radiation therapy, ablation, or surgical resection for our patients that have disease not only in the liver, but other sites, extrahepatic disease, and does this improve their overall survival? This trial literally just opened up last week or 2 weeks ago, if at all, and it's enrolling right now with an N of 364 patients. And then we also hope to have this open this spring. This is EA 2222, which is already approved by the GI Steering Committee, and it's looking at the role of hepatic arterial infusion, being led by Dr. Michael Lidsky. So please consider opening up this trial and enrolling patients if possible. This is the first prospective analysis to be conducted in a national setting regarding HAI. And last but not least, I want to touch upon anal carcinoma. I want to remind you, we still have EA 2182, which is currently still enrolling for early stage T1, T2, and 0 patients, trying to determine whether or not we can potentially omit the second dose of mitomycin, as well as reduce the dose of radiation therapy without compromising efficacy. This is a 2-to-1 randomization. Disease control is the primary endpoint. What other trials do we have that are pending results? We're still waiting. I apologize. I'm missing, sorry. Oh, here it is. We have EA 2165, that is, I'm sorry, I have these out of order. EA 2165 is currently pending final report, which is looking at the role of adjuvant nivolumab following completion of concurrent chemoradiation therapy in our high-risk recurrent anal carcinoma patients, so those with a tumor greater than 4 centimeters and those that were node positive. This trial enrolled very quickly, and we're waiting for it to be reported out. What about our newly diagnosed treatment naive patients? Well, we do have the EA 2176 trial that is open currently. It's about halfway through with enrollment. It's a 2-to-1 randomization of carboplatin plus paclitaxel plus or minus nivolumab, followed by maintenance nivolumab. And the primary endpoint here is progression-free survival. And we are also collecting HPV circulating tumor DNA as a correlative. This trial is supported by ECOG, as well as the Farrah Fawcett Foundation with the grant, and the circulating tumor DNA correlatives are being supported by Sysmex. So please enroll to this clinical trial if you have available to you. It is the first NCI supported phase 3 trial in the metastatic setting. So I'm very proud of this work, and I hope to get this completed as soon as possible in the hopes of creating a new standard of care. What other pending trials do we have? We have the NCI 9673, which has completed enrollment, nivolumab plus or minus ipilimumab in previously treated metastatic squamous cell carcinoma patients. Primary endpoint is progression-free survival, and we are hoping to report that out within the next year, the final results. I want to mention the SCARES trial that was completed in France, which was looking at DCF plus or minus atezolizumab. This was a 2-to-1 randomization. And I apologize for a little bit of the formatting issue here when it was transferred. But in short, the primary endpoint was progression-free survival, and there was no difference with the addition of IO therapy with DCF, which is a little surprising. We now know that obviously carboplatin or platinum-based therapies do well in combination with immune checkpoint inhibition in both squamous lung carcinoma as well as cervical carcinoma. So we believe that there should be no reason why we should not see some additional benefit for IO therapy in combination with platinum-based treatment. And that's why we're hoping the data from EA 2176 will validate this approach for our newly diagnosed metastatic patients. And that once again, there is the study design as mentioned earlier. I just like to highlight, please keep in mind our young adult patient population. They do have unmet needs. We are one of 5 young adult cancer programs across the country, which focus on all cancers. Our patient population that we are focusing on at Vanderbilt Ingram Cancer Center are those that are between the ages of 20 and 45 years of age. My colleagues and co-chairs are Elizabeth Davis, who's a sarcoma specialist, and Baghi Dalaria, who is a BMT specialist. And we're so grateful for their support, as well as support from other other grants and other institutions. So please just think about your young adult patients and their unmet needs in regards to financial security, job security, stress, body imaging, reproductive health, etc. So please just be thoughtful of your young adult patients. And want to remind you, of course, March is Colorectal Cancer Awareness Month, and please help promote cancer screening at 45 years of age and up or earlier if you have clinical symptoms. Fight CRC is a very large patient advocate organization, and I want to remind you once again, sometimes it is not our older patient that you will see in our clinic. I know the average age patient in the United States is 67, but on the right here is a young woman named Jessica who came to me when she was 32 years of age and had liver involvement at presentation. And unfortunately, this is now the new face of colorectal carcinoma as your young adult patient population, which has been rising in annual incidence of a little less than 3% per year for the past decade. For our anal carcinoma patients, once again, also increasing in incidence, as mentioned earlier, also a little less than 3%. We need to bring increased recognition and education regarding colorectal cancer and anal carcinoma. Michelle Longabaugh was a nurse, author, blogger, and NCI patient advocate. And unfortunately, she passed away unexpectedly, not necessarily due to her tumor, but it was a long-standing survivor of metastatic disease. And we are so grateful to her for speaking on behalf of other patients and connecting us with others in regards to education and awareness. So thank you so much for your attention, and hopefully you've learned something from this experience. And I'd like to thank the OncoAlert team for allowing me this opportunity to educate you about what I think has been important to acknowledge in colorectal and anal carcinoma.
My name is Dr. Sharlene Gill. I'm a GI medical oncologist based out of BC Cancer in Vancouver, and really delighted to be able to present to you updates in gastric and esophageal cancer as part of this OncoAlert colloquium. These are my disclosures. So I'm going to start, it's been a busy year in esophageal and gastric cancers. I'm going to start by talking about early stage disease. And we knew from Checkmate 577 that was published in 2021 that the use of a year of adjuvant nivolumab was associated with benefit in patients who with esophageal or GE junction adenocarcinoma or squamous cell cancers who had received neoadjuvant chemoradiation and at the time of resection had evidence of pathologic residual disease. And so to remind you, in Checkmate 577, patients were randomized in a 2-to-1 fashion to receive either postoperative standard of care, which was surveillance and placebo, or nivolumab given initially every 2 weeks for 16 weeks, then followed by monthly for up to a year. And what we saw in Checkmate 577 was a significant improvement in the primary endpoint of disease-free survival, almost doubling in the median disease-free survival and hazard ratio of 0.69 with the use of adjuvant nivolumab therapy. And while the overall survival results from Checkmate 577 are still pending, based on the DFS endpoint, this has changed standard of care in this setting, and now a year of adjuvant nivolumab is a funded option in Canada and in many jurisdictions around the world in patients with esophageal and GE junctional cancers post-neoadjuvant chemoradiation with YPR. Now, this update is reflected in the most recent ESMO guidelines for esophageal cancer, where the use of adjuvant nivolumab is now recommended following neoadjuvant chemoradiation. The question remains, of course, for those patients who are treated in a perioperative chemotherapy fashion with FLOT as sort of the more commonly used or preferred perioperative regimen. What is the role of immunotherapy in that setting? And so this year, we heard of the interim results from Dante. Dante is a randomized phase 2b study of perioperative FLOT plus or minus atezolizumab. So Dante is a study conducted in Germany and Switzerland. Patients, almost 300 patients were randomized, and these were patients with adenocarcinoma of the GE junction or stomach. randomized in a 1-to-1 fashion to standard perioperative FLOT chemotherapy with surgery, or FLOT plus atezolizumab, the PD-L1 inhibitor, followed by surgery, followed by postoperative FLOT and atezolizumab, and a further 6 months of atezo given in an adjuvant fashion. The interim results reflected the secondary endpoints, PCR, tumor regression grade, PTNM, and the R0 rate. And we heard of the safety results from the Dante trial and saw that there were no significant differences with the addition of atezo to the incidence of serious adverse events or surgical morbidity or mortality. In terms of the pathologic outcome data, a PCR of 23% was observed with the addition of atezo to perioperative FLOT versus 14% with FLOT alone, kind of consistent with what we would expect in this population. Looking at the tumor regression grade by the Becker classification, we do see in column A reflecting the atezo arm, and B the standard of care with FLOT alone arm, a higher proportion of tumor regression observed with the addition of atezolizumab. And as the tumor PD-L1 CPS score increases, and certainly in patients with deficient mismatch repair disease, that difference is amplified, and these findings justified a transition to the phase 3 trial. In addition to Dante, perioperative studies that are we're looking ahead to in this space are Matterhorn, which is FLOT plus durvalumab in a similar fashion, and Keynote 585, which is looking at the use of pembrolizumab with perioperative FLOT, again followed by postoperative immunotherapy given for a longer duration of 6 months to a year. At the end of last year, we also heard of a press release from Attraction 5, and Attraction 5 is a phase 3 study conducted in Asia in a population of patients with pathologic stage 3 GE junction or gastric adenocarcinomas, and looked at the benefit of adding nivolumab to the postoperative adjuvant chemotherapy, in this case of S1 or CAPOX. This trial intended to accrue 800 patients, and based on the press release, we have learned that it did not reach the relapse-free survival endpoint. And I think it may raise some questions as to what is the utility of that post-operative adjuvant immunotherapy given even for the perioperative studies, beyond the perioperative chemotherapy approach. And in fact, is most of the benefit that is being seen from the neoadjuvant component. So we will await the full results, but I think there is still many questions to be answered in this space. Focusing on the subset of patients with deficient mismatch repair, esophageal and gastric cancers, we believe that DMMR is seen in about 8 to 10% of patients in this setting. And in this meta-analysis, which it looked at patients from a number of perioperative chemotherapy trials, it was reported that deficient mismatch repair status is a favorable prognostic feature in early stage gastric cancer, but perioperative 5-FU-based chemotherapy was not associated with benefit in this subset. And in fact, there was a suggestion of inferior outcomes with the use of chemotherapy, and we have heard a similar story in colon cancer. And the question really is, should these patients proceed directly to surgery rather than considering a perioperative approach? And more topically, what is the role of immunotherapy in this subset of patients? Early last year, we heard of the results from the phase 2 Neonipiga trial, a French intergroup AJURCOR study, looking at the role of neoadjuvant nivolumab and ipilimumab, followed by adjuvant nivolumab in patients with deficient mismatch repair, gastric or GE junctional adenocarcinomas. So this was the study schema for the Neonipiga trial. Patients received 12 weeks of nivolumab and ipi, 2 cycles of nivo and ipi, followed by 2 cycles of nivo. And following resection, patients then were offered 9 months of adjuvant nivolumab therapy and then followed on surveillance. The primary objective for this trial, this phase 2 trial, was pathologic complete response. And we heard that the use of neoadjuvant nivo-ipi was associated with a pathologic CR rate, a complete tumor regression observed in almost 59% of patients. With a median follow-up of a year at the time it was reported, 31 patients were alive, all 31 patients were alive, and 30 without evidence of relapse. So, 59% PCR rate with no new safety concerns is certainly very intriguing. And again, this potential for organ preservation in this subset of patients, particularly when surgery is associated with significant morbidity. We've heard this discussion, of course, in rectal cancer and in gastric cancer. The morbidity of surgery is not insignificant. So this is certainly an area worthy of further exploration. It does mean that we need to be ascertaining tumor MMR status for our patients with early stage gastric and GE junctional cancers. I think the other reality, given the increasing evidence in the space of neoadjuvant immunotherapy in dMMR disease, is that we understand that randomized studies will likely not be possible due to the lack of clinical equipoise. It will be very difficult to randomly assign patients to no immunotherapy when we know they have dMMR disease. And so in order to change standard of care, and in jurisdictions like mine in Canada, in order to secure funding for these therapies, we will need more evidence, and with survival endpoints, so longer follow-up is going to be necessary, and multi-institutional phase 2 studies to broaden the generalizability of these findings is also important. I think some of the unanswered questions is, again, do we need, as in neonipiga, the 9 months of adjuvant nivolumab that was offered, do we need that neoadjuvant, that postoperative, adjuvant component, or is this all driven by neoadjuvant therapy? Would there be benefit to combining with chemotherapy in this setting? And can we extrapolate to other disease sites? And along that line, I think, just published online in JCO last week was this very interesting study from MD Anderson looking at neoadjuvant pembrolizumab, again in dMMR, a spectrum of solid tumors. So 35 patients were included in this report, predominantly GI and colorectal, but also included pancreatic and gastric cancer. And patients received 6 weeks of pembrolizumab, followed by response assessment. The overall response rate in all 35 subjects was 82%, a clinical complete response of 30%. And for those patients who went to surgery and were evaluable for pathologic complete response, which was 15 patients, the PCR rate was 67%. Most of those patients were patients with colorectal cancer who went on to surgery. But when we look at sort of the waterfall plot looking at the clinical responses and correlating them with pathologic complete response, we do see a discrepancy in that many pathologic complete responses were not associated with a clinical complete response. And I think this really kind of reminds us of the importance of better sort of imaging and ascertainment for true residual disease in this setting where we don't see a clinical complete response, particularly challenging for non-luminal cancers. I think for luminal cancers, we know we have the benefit of endoscopy, but certainly this adds to the data in this setting of the potential utility of neoadjuvant immunotherapy as an organ preservation approach for deficient mismatch repair disease. Moving into the advanced disease setting, I think what we saw last year really was a sort of a reflection of how to integrate the considerable data that had come forward in 2020 and 2021 of the role of immunotherapy and how that's really changed the landscape in the first line setting for patients with esophageal and gastric cancers. And so what was relevant in this space are the updated ASCO and ESMO guidelines. And the ASCO guidelines were published again just in January 2023, focusing on the recommendations for immunotherapy and targeted therapy. And the ESMO guidelines were published last summer. So in the ESMO guidelines for advanced esophageal squamous cell cancers, just to highlight that the ESMO guidelines look at tumor stratification based on PD-L1 status, and they acknowledged the findings from Keynote 590, where pembrolizumab demonstrated a survival benefit in patients with esophageal cancer in the first-line setting, and particularly in patients with a PD-L1 CPS score greater than 10. So as well, the Checkmate 648 study in esophageal squamous cell cancers of nivolumab plus chemotherapy versus chemotherapy alone, or the option of nivo plus ipi. And in Checkmate 648, the biomarker for PD-L1 ascertainment was PD-L1 tumor positive score. So in that case, a TPS greater than 1%. And so the ESMO guidelines have recommended nivolumab in that setting. And for those patients who are PD-L1 negative tumors, chemotherapy is recommended with nivolumab reserved for the second-line setting, and a taxane and irinotecan be reserved for post-progression therapy. The ESMO guidelines for advanced gastric cancer also reflect upon the data from Checkmate 649, which, as we know, was examined the role of nivolumab plus chemotherapy versus standard of care chemotherapy in advanced gastric cancer. And the primary endpoint of that trial was looking at the benefit of nivolumab in a PD-L1 CPS greater than 5 cohort, although it was an all-comers trial, and the PD-L1 CPS greater than 5 represented 60% of the patients in this trial. So in the current updated ESMO guidelines, as published in 2022, for the first-line treatment for advanced and unresectable gastric cancer still includes a platinum and fluoropyrimidine doublet, and we know in contemporary practice this is currently most commonly FOLFOX or a CAPOX-based regimen. For those 15 to 20% of patients who are HER2 positive, the addition of trastuzumab remains the standard of care, so no changes there. But for those who are PD-L1 type positive tumors, the addition of nivolumab is recommended. Notably, the ESMO guidelines do not restrict this to PD-L1 CPS greater than 5 and recommend consideration for the adjuvant of nivolumab for all PD-L1 positive tumors. The ASCO guideline, in somewhat of a contrast, was kind of more focused on addressing two clinical questions. What is the role of immunotherapy or targeted therapy in combination with chemotherapy in the first-line setting for both gastroesophageal adenocarcinoma or squamous cell cancers? For these subgroups of patients, those who are HER2 negative and express PD-L1, either as TPS, tumor positive score, or combined positive score, or those with HER2 positive gastric or GI junctional adenocarcinomas. And they also explore the questions: what is the role of such therapies, immunotherapy or targeted therapy, in second or third line? And this is the sort of the key figure from the guideline. And notably, starting first with the patients with HER2 negative disease, the guideline assigns patients based on tumor location, gastric, GE junctional, or esophageal adenocarcinomas, and then esophageal squamous cell cancers, and then stratifies recommendations based on PD-L1 score. So for esophageal squames, I think irrespective of PD-L1 score, the addition of immunotherapy is recommended, either in combination with chemotherapy or a nivo-ipi combination for a chemo-free option. For patients with adenocarcinoma, there is a nod and an acknowledgement to using tumor PD-L1 CPS score, and notably for those patients who have a low PD-L1 CPS score 1 to 5, the addition of nivolumab to chemotherapy versus chemotherapy alone in gastric cancer it's recommended that it be considered, but on a case-by-case basis, as reflected in those gray boxes, whereas high PD-L1 CPS score was associated with a fairly straightforward, clear recommendation to consider the addition of a PD-1 inhibitor. And for post-progression or second-line therapy, it was recommended that the standard of care remain, the current recommendation of ramucirumab plus paclitaxel based on the Rainbow trial. In HER2 positive, and I think this is where there's a bit of a distinction from the ESMO guidelines as well, the use of trastuzumab plus pertuzumab in combination with plus pembrolizumab in combination with chemotherapy is recommended. And that addition of pembrolizumab in that setting, in the first-line setting, is based on the interim results from the KEYNOTE-811 trial, which is pembrolizumab plus trastuzumab and chemotherapy in HER2-positive disease. And while in many jurisdictions, including Canada, the use of pembrolizumab in that setting will be reserved until the survival data is available. This is reflected in the ASCO guidelines. And as we saw in the ESMO guidelines, this is not yet an ESMO recommendation. Again, I think awaiting the survival data from KEYNOTE-811. As well, in the ASCO guidelines at the time of progression, trastuzumab deruxtecan or TDXD is recommended, that the antibody drug conjugate. This is based on the Destiny Gastric data, which has demonstrated the response rate benefit and PFS efficacy. These are non-comparative trials of TDXD, even in patients who've received prior trastuzumab. So I think the ASCO guidelines within the HER2 space reflect I guess, a more progressive approach to HER2-directed therapies, and most other jurisdictions, I think, will have to await more evidence for that to change practice. Looking forward in terms of molecular subgroups, I think this is really kind of what's going to be exciting for in 2023 and beyond. For those, we know that at GI ASCO in January 2023, we're going to hear of the data from the Spotlight trial, which we know based on a press release is positive, looking at the role of zolbetuximab in Claudin 18.2 positive HER2 negative disease. And press release has also suggested that the GLOW trial is positive. So these are looking at FOLFOX and CAPOX-based regimens with zolbetuximab in the almost 40% of patients with Claudin positive disease. A lot of activity in their HER2 positive setting, not only with pembrolizumab and trastuzumab deruxtecan, as I mentioned, in terms of more mature data from KEYNOTE-811 and the Destiny Gastric trials, but also looking at tucatinib based on the Mountaineer phase 3 study and zanidatamib, HER2 bispecific, with the ongoing trial of the Horizon GEA-01 in the first-line setting, with or without the PD-1 inhibitor tislelizumab. And finally, FGFR2 fusions. We know that based on the FIGHT data, bemarituzumab has activity in this setting, and Fortitude-101 is now looking at the use of this agent in first line in FGFR2b positive gastric cancer in combination with chemotherapy. So I think a lot to look forward to ahead in terms of molecularly directed therapies in gastric cancer. So with that, I thank you very much for your attention.
Hi, my name is Allison Rosen, and I am a stage 2 colorectal cancer survivor and passionate patient policy and research advocate. I'm beyond honored to be here today to talk to you about colorectal cancer as a patient advocate and what I've seen in trends over the past year. To start, I want to give you a little bit of background about myself. I am a 10-year colorectal cancer survivor, early age onset survivor. I have a history of Crohn's disease and asthma. Throughout my treatment, I had 4 open abdominal surgeries. My treatment included radiation and oral chemotherapy. A few other things that my treatment left me with were a lovely permanent ileostomy. I am a sepsis survivor. I suffer from kidney disease, including multiple infections and kidney stones, as a result of my treatment as well. And my cognitive ability was affected. Other things that aren't necessarily in here are that the radiation put me into menopause, so I can no longer have children. I lost my hair due to my treatment and complications, a lot of other things that can affect a cancer patient. So I'm going to talk to you about different things I've seen trending over the past year, but also I want to remind you, so I'm a cancer survivor, and I feel like the minute you're diagnosed, you're considered a survivor. But a lot of the things that I mentioned above here and a lot of the things that I'm excited about will help with cancer survivorship. What does cancer survivorship mean? To me, it's living with, through, and beyond a cancer diagnosis. And that definition comes from National Coalition for Cancer Survivorship. And I truly believe that that sort of embodies what I mean when I say cancer survivorship. So Here's the slide that I think is most important. These are 4 different things that I found throughout the past year that have popped up, that are the most popular, that have been the center of the colorectal cancer world. First is trials in targeted therapy. It used to be very simple, well, not very simple. Standard care for colorectal cancer, depending on stage, was either surgery, radiation, chemotherapy, combination, and multiple different, options as far as that's concerned. But now with different trials, Beacon, IDEA, Cobra, a bunch of these trials are showing less is more when it comes to colorectal cancer treatment. So if it's better to have Kpox at a 3-month versus 6 months, and there's no difference between the effectiveness of it, then you should do a treatment that's less. If it's better to have or HIPEC surgery, if it doesn't benefit the patient and it just creates long-term effects around survivorship and long-term effects as far as quality of life, that it shouldn't be done. So that's the trend that I saw a lot in 2020. And I also saw a lot of trials, which I love. Combination of drugs, different drugs, immunotherapy drugs, PD-L1 inhibitors, so many different drugs and trials being used to try to help at the center make the patient experience better, have the long-term effects be less. Patients are living longer from colorectal cancer because they're getting diagnosed earlier. The other trial I want to mention that got the most media buzz, I think, over the past year was Dr. Sersek's LARC study, where all 10 patients were put into full remission. And I think this is a trend that this was great. It was very successful. It got a lot of attention. Now we're going to take, I know I've heard from Dr. Sersek and other people, they're going to use what she's learned and continue more trials with more mutations to see how that will affect the cancer patient. But I was so excited, as the world was, when it came out with full response for those patients. Yes, it is a small subset of colorectal cancer patients, but it's still a subset of colorectal cancer patients. And it opens the eyes and minds to so many researchers that are working on trials. Next thing is multi-cancer early detection tests. It's the new rage. I think the best test for colorectal cancer is the one that gets done. And we have millions and millions of people that have not had their colonoscopy or FIT test or Cologuard or stool-based test. So a blood test, the idea of a blood test to detect cancer early, still having to have that colonoscopy if it's positive is huge. You can have these blood tests in your PCP as a part of your physical. So I know there are a lot of companies that are doing these or trying to come out with these. The first one to come out, it's been very successful and shown promising results from Guardant Health is Shield. But I know Exact, Grail, and a bunch of other groups are working on a blood test. And I think as a patient advocate, if I can add that to my list of tests to tell people they can do for colorectal cancer screening, it's going to have huge impact in the community. Thirdly, on here, shared decision-making. I think we're moving towards a more patient-centered care. We are moving towards more patient-centered care. And that shared decision-making is a buzzword. I think really all that means is when the doctor and the patient work together to make the best decision based on knowledge, based on research, based on experience, and based on the patient's values and what they want. If they're younger, they might have different long-term goals than someone that might be older. So really talking to the patient, getting to know them, and then creating customized treatment plans for that patient based on their stage, where they are in life, and their wishes. And so lastly on here, obviously, as an early age onset colorectal cancer survivor, the stat that I have on here, which I think I read a tweet of recently, is current. The research showed that by 2030, researchers predict that colorectal cancer will be the leading cause of cancer-related death in 20 to 49-year-olds. And I read a tweet, I think it was last week, that said this is happening right now. So the fact that we thought it would happen by 2030 and it's happening right now means we need more funding, we need more research, and we need more screening for early age onset to catch early age onset cancer earlier. Now, is that community outreach? Is that education? Is that policy changes? Is that more research? That's all of the above. I think we need all of the above. We need to empower the patients and the communities, but we also need to make sure that the medical professionals, healthcare professionals, know that if you have a colon, you're at risk. And if you're younger, just because you're not 45 or older, doesn't mean you can't get colorectal cancer. So if they come in with typical signs and symptoms for colorectal cancer, refer them to GI for that colonoscopy. It just makes sense. And as we get closer and closer to 2030, and as this trend keeps increasing, we're going to have to make a change to make sure younger patients are being screened. With that, I know I only have a few minutes, but I truly believe these are a bunch of patient advocates that I love throughout the world, different groups that I work with. I truly believe that if we all work together, myself and the patient advocacy community, and you all as healthcare providers and other patient advocates listening, we can save lives. We can take the technologies, we can take the trials, we can take the advocacy, we can take the education, and we can help save lives and make that screening rate go up and the mortality and incidence go down. So with that, I want to say thank you so much. And if you're interested in collaborating, I'm a patient advocate on multiple grants. Just reach out to me. I'd happily connect. And if I'm not the right person, I will put you in touch with the right person. Our goal is to end this disease in our lifetime. And I'd love to be a part of what is happening in your world.
Hello, OncoAlert family. My name is Mark Lewis. I am a GI medical oncologist practicing in the United States at Intermountain Health. And it is absolutely my privilege to join you for this colloquium. Once again, I have to thank Gill Morgan for assembling such a breadth of talent and expertise in our field. And I'm increasingly struck with the need for both breadth and depth. And today we're going to be taking a deep dive into pancreatic cancer. Certainly some updates to share with you since our last colloquium. Unfortunately, I would argue not huge paradigm shifts, but I think you'll see the benefit of splitting rather than lumping, in the sense that we are making headway through subset analysis and identification of particular groups who are candidates for specific therapies. So without further ado, we'll take a look here at our agenda. So the first thing we're going to talk about, I think you'll see this theme echoing throughout the talk, is to review biomarker-informed care of pancreatic ductal adenocarcinoma, talk about treatment sequencing, think specifically about borderline resectable PDAC, then kind of broaden our lens and understand the indications and implications of germline testing. And then finally, let's not forget that this is a very interesting, complex organ, and it's not just about the exocrine cells. So we're also going to talk about pancreatic neuroendocrine tumors. So we're going to look at the endocrine pancreas as well. So let's go to last year's ASCO. This was a really interesting study of a sort of tongue-tying polysyllabic antibody, zenocutuzumab. And this is specifically targeting NRG1 fusions. And the way the antibody actually works is it's preventing, through a bispecific binding, the heterodimerization of HER2 and HER3, which then leads to downstream oncogenic transformation. And none other than Vivek Subbiah, who I believe is also a colloquium participant, described NRG1 fusions as the next great target in histology agnosticism, sort of building on successes with NTRK and with RET. Of course, no one knows more about that than Dr. Subbiah. But as a GI oncologist, this study really heartened me. Now, again, to be clear, if you take all comers in terms of solid tumors, the incidence of NRG1 fusions is about 0.2%, but it turns out it's specifically enriched in non-small cell lung cancer, specifically mucinous adenocarcinoma, and also in pancreatic ductal adenocarcinoma. So in this particular study presented at the last ASCO annual meeting, there were 79 evaluable patients, of whom 19 had PDAC, and 8 of those had an investigator-assessed RECIST response, as is shown here in the waterfall plot. It's also really important to mention that KRAS, one of the most common, arguably canonical mutations that we encounter when we look in the PDAC genome, is no longer to be considered undruggable. And actually, for many years, I would argue it was the example par excellence of a mutation that we could find and yet not action. Now, again, to be clear, in our alphabet soup, and I definitely get into these nuances with patients, the vast minority of PDAC patients will harbor a KRAS G12C. However, if they do, there's definitely something we can exploit therapeutically. So analysis of the structure of the KRAS G12C bound to GDP revealed a previously unknown binding pocket in the switch 2 region. And we now have drugs, adagrasib and sotorasib, that can irreversibly and selectively bind that pocket. This is present in the mutant KRAS G12C and then locks it in the inactive GDP-bound state, which inhibits oncogenic signaling. So this is data from Crystal with a K, presented by Dr. Saab last year's ASCO GI. Again, not huge numbers, but this is pretty remarkable in the sense that Dr. Saab showed us 10 patients, half of whom, so 5 of 10, had objective response, and all of whom had disease control with a median duration of response approaching 7 months. Sort of a rising tide lifts all boats. Similarly, we've seen data and now published in the New England Journal regarding the other KRAS G12C inhibitor, sotorasib, and its efficacy in the same patient population. So again, this is Codebreak 100 subset printed in the New England Journal earlier this month. This was a pooled population from both the phase 1 and the phase 2 of that study. Consisted of 38 patients, all of whom had metastatic disease and had previously received chemotherapy. At baseline, they had a median of 2 prior lines of therapy, but that actually ranged up to 8. All 38 patients received sotorasib, and after dose finding, they actually settled on the 960 milligram daily dose. A total of 8 patients had essentially confirmed objective response. So as you can see there in the synoptic caption, it's about a fifth of people responding. But I think probably just as importantly, especially in talking to patients, the disease control rate was above 80%. Median PFS was 4 months, and median OS was still sobering 6.9 months. But my point again is we only find what we look for, and we really have to shirk a notion or an attitude of therapeutic nihilism in pancreatic ductal adenocarcinoma, as I plan to expand on later. By doing sort of deep analysis of the cancer genome, we do find now and again mutations which previously were unactionable and now can be targeted. And then I don't know if it's quite ready for prime time, but I think I'd be remiss not to mention this publication in the New England Journal last summer of a cellular therapy that was deployed in KRAS mutant PDAC. And this time we're not talking about G12C, we're talking about G12D, which is much more prevalent. So this is a patient from Oregon who had progressive metastatic pancreas cancer, treated with a single infusion of autologous T cells. So these have been genetically engineered to clonally express 2 allogeneic HLA-C T cell receptors that targeted the mutant KRAS G12D. And this patient experienced regression of their visceral metastases, which, as you can see from the CT imaging, were largely in the lungs, so maybe a different biology. But regardless, they showed that these T cells actually ended up, even long after infusion, accounting for about 2% of all the circulating T cells in the patient's bloodstream 6 months after cell transfer. And this appeared to really kind of open a new avenue of approaching PDAC with cellular therapy. So I think a lot more to come here, but exciting to see this N of 1 published in such a prominent journal. You know, sometimes when I'm faced with a very lethal cancer like pancreatic ductal adenocarcinoma, I sort of put a lot of pressure on myself to make the first line of treatment, to make that decision the be all end all. But the truth is very interesting. I think a lot of us are in the habit of starting one line of treatment and essentially continuing it until either progression or unacceptable toxicity, or both. And this trial sequence presented by Dr. Curato at the last ASCO annual meeting really takes a very different look at the limited armamentarium that we have in PDAC. So all GI oncologists know we have few drugs to work with, but by sort of mixing mechanisms of action, or at least sequencing mechanisms of action, can we actually extract more value, more durable benefit out of the drugs? And the answer is a tentative yes. So one of the things that's so fascinating about sequence is, as you can see here in the schema, 1-to-1 randomization to either gemcitabine nab-paclitaxel or gemcitabine nab-paclitaxel with a predetermined switch point to FOLFOX, and then alternating back again every 6 weeks until progressive disease or, again, unacceptable toxicity. Really a fascinating trial design. Now, their primary endpoint was the 12-month overall survival rate. And you can see here that more than half of the patients on the alternating sequence were alive at 12 months, so 55.3% versus 35.4% in just the straight nab-paclitaxel gemcitabine with a statistically significant p-value. For what it's worth, at 24 months, the respective OS rates were 22.4% versus 7%. So again, the alternation appeared to have some durable benefit for patients, even continuing into the second year. This again is overall survival by treatment arm. Again, rather remarkable, I think, to see a median overall survival of more than a year. Again, sobering that it's only 13.2 months. But regardless, I think a really key takeaway that we don't just need to commit to one regimen and use it ad infinitum or ad nauseum. Really sort of pre-planning alternation may make some sense. Here, for what it's worth, are more data on efficacy, including the overall response rate essentially being double in the alternating arm. Disease control rate not being statistically significant, but trending towards a higher level of DCR in the alternating arm. And to be honest with you, in terms of PFS, it looked like 7.8 versus 5.2 months. And you might ask, well, what's the trade-off here? The trade-off is a slightly increased risk of grade 3 plus hematologic toxicity, especially in regard to neutropenia, and also an increase in all grade neurologic events, which presumably includes neuropathy with the sequencing of the nab-paclitaxel and then the oxaliplatin. So watch this space, but really an intriguing approach, and I applaud the investigators for what I think is a quite innovative trial design, showing us how to make the most of what we have. Now, this was literally hot off the press, and I am so grateful to Gill for letting me attend ASCO GI this year before putting together my talk, because I'll admit I had really high hopes for NAPOLI-3. I thought maybe this would establish a new standard of care in the treatment-naive metastatic setting. And I'll be very honest to editorialize, I don't think it's a new standard of care. What happened here was a 1-to-1 randomization between the NALIRIFOX triplet. And again, just to be very specific here, look at the doses in that gray box. So the liposomal irinotecan is at 50 milligrams per square meter, and the oxaliplatin is at 60 milligrams per square meter. And Dr. Weinberg, in his discussion and in the Q&A, sort of stressed that while these doses appear unconventional, they were reached through sort of traditional dose-finding strategies in earlier phases. So I think, again, due diligence was done there. And this was, again, being compared against gemcitabine nab-paclitaxel. And the findings were interesting insofar as the median overall survival was longer in the triplets. So in NALIRIFOX, the median overall survival was 11.1 months versus in the nab-paclitaxel arm, it was 9.2 months. But here's what I can't help doing, and I know we're not supposed to do this, but the comparison to the now decade-plus old Perdige data, the Accord data, or the Unicancer data, whatever you want to call it, the seminal publication in the New England Journal in 2011, comparing FOLFIRINOX versus gemcitabine, and the median overall survival for the triplet exactly the same at 11.1 months. So I think there were some understandable questions being asked at ASCO GI, specifically of Dr. Weinberg, saying, well, why would you use NALIRIFOX over FOLFIRINOX, especially since we have, I think, more comfort with modified FOLFIRINOX, especially from about 2018 onward. And his response was fair, but I think he was working with the data that he had. I think there's some very putative benefits here to the NALIRIFOX triplet. I'm personally very interested to see if we get any subset analysis of sort of locally advanced borderline resectable pancreas cancer rather than frankly metastatic, because putatively the nanoliposomal vehicle might allow better penetration of peritumoral stroma, more response to intact primaries. But until I see that, I'm not really convinced that this is a better mousetrap, if you will, than modified FOLFIRINOX. So watch this space. And then, as I've already hinted, I'm really fascinated in what do we do about pancreatic cancers, adenocarcinomas that are still confined to the pancreas, especially vis-a-vis the sometimes intimate and troubling relationship to peripancreatic vasculature. So we have a host of trials now looking at the question of, well, what chemo do we give? Do we sequence chemo and radiation? We have LAP-07, which I think was rather disappointing in terms of chemoradiation following on the heels of induction chemotherapy. We also have A021501, again, showing that a radiation chaser after FOLFIRINOX induction did not necessarily render patients more operable. But what I'm interested in here is sort of the juxtaposition and similar messaging, I think, of S1505 and JCOG 1407. So on the left, again, a SWOG study looking again at patients with still intact primary tumors. And, SWOG 1505 was not powered to answer these questions, but I think it's really fascinating to note, again, how the overall survival curves of modified FOLFIRINOX in red and top left, and gem-nab-paclitaxel in blue, again, top left, basically track together. And then again, these numbers are modest, but actually, if you look below in the table, the complete or major pathologic response was higher in the doublet versus the triplet. And I'll admit my own cognitive bias. I assumed, more drugs is better. There have been, again, conjectures that perhaps the nanoparticle albumin-bound paclitaxel does a better job of actually getting into a primary pancreatic mass. I need to see a little bit more data there. But regardless, I think we can conclude from S1505, again, given its attendant caveats, that this doublet is not inferior to modified FOLFIRINOX there. And then when you look at the JCOG data, again, they were treating locally advanced pancreatic cancer. And sort of the same message, so a randomization 1-to-1 to receive modified FOLFIRINOX versus gem/nab-paclitaxel, and really no salient differences in median overall survival, so 23 versus 21 months. Median PFS was 11 versus 9.4 months, triplet versus doublet. And then again, fascinatingly, a higher response rate in the doublet. So the doublet, the response rate was 57%. In the triplet, it was 31%. And then finally, worth noting, less toxicity with the doublet versus the triplet. So again, I think we're still finding our way on how to approach the still intact, borderline resectable / locally advanced PDAC. Absolutely sort of ripe for discussion, and appropriately so, in multidisciplinary tumor boards and with surgeons who can best opine on how extricable or not the vessels will prove from the tumor itself. But again, I would not at this point underestimate the potential benefit of a doublet, especially when it goes head to head with a potent triplet like modified FOLFIRINOX. I think a lot of you know I have an inherited tumor syndrome myself, and so I'm very passionate, both personally and professionally, about family history. Again, every iteration of the NCCN guidelines, I think from 2021 onward, has sort of driven home the point that genetic testing for inherited mutations is indicated for every patient with pancreatic ductal adenocarcinoma. There's been some slight change to the language since they first put out the guidelines, but again, I've boxed and read what I think is the most salient point here. And really, I think the reason that this matters is it brings us a little bit closer to precision medicine in PDAC. So on the left, I think a very elegant diagram from JCO last summer, showing some of the things we've already hinted at, looking for these sort of unicorn fusions, NTRK, ROS1, ALK. We talked about NRG1. Dr. Spaya mentioned RET. All wonderful if we find them. But then kind of going deeper and then hinting at the KRAS inhibitors that we've already discussed. But then I also wanted to address DNA damage repair defects. And really my message here is, every square is a rectangle, not every rectangle is a square. So when you find a DDR defect in the tumor, it doesn't necessarily mean it's present in the germline. But if you know a patient has a germline predisposition to a DNA damage repair defect, then that certainly you would expect that to appear in the tumor genome as well. And we're increasingly finding our way about what that means in terms of platinum sensitivity, subsequent use of PARP inhibitors. POLO, which we've discussed previously, was rather pilloried for the FOLFIRINOX to olaparib switch, with some critics feeling like the platinum exposure was inadequate upfront. But regardless, this slide is essentially to drive home the point that there's a lot more going on in DNA damage repair defects than just BRCA. And when you really start to get granular, there's both HRD and non-homologous end joining to be considered. All right, we're on the home stretch here. This I thought was a beautiful pie chart from Nature Cancer last year, showing really all the mutations in KRAS. So as we've already discussed, KRAS G12C currently the most actionable, also a minority, so maybe a 1 to 2% slice of the pie. G12D, we've already referred to with the promise of TCR therapy. We still need to crack the code of G12V and G12R. And then I like the call out here on the right, sort of that entire list of fusions, which again, usually get us beyond the primary site to as close as we're going to come to histology agnosticism. And then finally, as I mentioned, and again, betraying my own personal bias, I would be remiss not to talk about neuroendocrine tumors. So this is a long-awaited and beautifully done manuscript by Pam Koons and colleagues looking at capecitabine and temozolomide for metastatic PNET. And, this is interesting because it really opens up and expands our toolbox for PNETs. For many years, sort of the classic cytotoxics that we were using in this space were everolimus or sunitinib. There have been hints, starting with single institutional work, I believe, from Moffitt in the late aughts, showing that CAP-10 held some promise. And this is a really nice analysis at, who's doing the heavy lifting here? I think the answer is the temozolomide. Dr. Koons and colleagues did some sort of subset analysis suggesting a role for MGMT analysis with deficiency, of course, then conferring a higher response and more sensitivity to the alkylator. And then you'll see on the graph on the right, there's a lot of effort here to sort of tease apart the effect or influence, I should say, of grade on response or progression-free survival. To me, actually, the takeaway here is not actually any huge difference between grade 1 and grade 2, but the fact that we should be considering CAP-10 in grade 1 and 2 at all. I'll have to admit my own anchoring on this notion that to use CAP-10, I really had to be dealing with a grade 3 tumor. I was usually thinking about a proliferative rate, K67, between 20 and 55%. I think this shows that we need to be thinking about CAP-10 even for our slower growing tumors. Which again is fascinating because, with the alkylator in particular, it makes you wonder if the effect is purely predicated on turnover rate or whether there might be some more durable DNA damage there that we can exploit therapeutically for our PNET patients. So in closing, there is progress in pancreas cancer, both adenocarcinoma and NETs. I'm thrilled to kind of put this together as a high level, rapid fire review. But as always, please refer to the primary sources and the references I've listed. And thank you so much to our fearless leader, Gill Morgan, for putting this all together. Gill, I know that you can take the man out of Texas, but you know how to finish that phrase. I raise a Topo Chico in your honor, and I wish all of you good health. Thank you so much.
Hi, everyone. My name is Nina Sanford. I am a GI radiation oncologist at UT Southwestern in Dallas, Texas. And it is my pleasure to present on updates in GI radiation therapy in 2002. So I separated the talk into 4 sections based on disease site. So we will start with rectal cancer, move on to pancreas cancer, then esophagus and gastric cancer, and lastly, anal cancer. I will focus on trials and studies presented at the annual meetings in 2022. So starting with rectal cancer. So I shared this slide to convey that there are many treatment options currently for locally advanced rectal cancer. So historically, the most standard used regimen was long course chemoradiation, followed by surgery, followed by adjuvant 5-FU-based chemotherapy. Now, that is probably one of the least common used regimens, and there are many other regimens that are much more commonly used. I listed them here in the bubbles. Basically, the 2 branch points are whether this is a surgical management strategy, an attempt at non-operative management, and then whether the patient will receive short course radiation therapy over 5 days or long course chemoradiation over 5 weeks. In red, I also listed the major studies either completed or currently enrolling, assessing these treatment regimens. I should explain that there are actually even more options than what's listed here in the corner. I write that in this figure, I did not include studies on assessing radiation dose escalation, the role of transanal excision surgery, and also systemic advances in the treatment of rectal cancer. So with that being said, I will move on to some studies. So probably the largest study in rectal cancer published last year was the OPRA trial. This was presented at, I believe, Big ASCO in 2021. The publication came out in JCO last year. So the OPRA trial was a trial assessing sequencing with the goal of achieving a complete response, allowing for watch and wait in locally advanced rectal cancer. So the sequences were either starting with long course chemoradiation and then moving to FOLFOX or CAPOX chemotherapy, versus the reverse of that, starting with chemotherapy and then moving to long course chemoradiation. The main finding of the study was that starting with radiation therapy led to higher rates of organ preservation, and that's shown in the table here, OP. So the rate of organ preservation when starting with chemoradiation was 58% versus 43% when starting with chemotherapy. And this is postulated to be due to a longer wait time after radiation, allowing more time for the tumor to respond. As you can imagine, there are many sort of offshoot secondary analyses from the OPRA study because there was so much to be learned from the trial. This was a poster presented at ASCO in June, and this was looking at clinical and radiologic predictors of a complete response in patients treated on the OPRA study, I believe, or I can't actually remember if this was on the OPRA study or just from Memorial Sloan Kettering, but anyway, predictors of a complete response, looking to see which patients are more likely to have a complete response. They found that the 3-year organ preservation for the whole cohort was about 50%, and that variables associated with a higher rate of complete response or a lower rate of complete response, I should say, were involvement of the mesorectal fascia, nodal involvement, and EMBI. So when counseling patients, we can look at those. These are radiographic predictors to see how likely they are to achieve a complete response. This is another study looking at how we can predict patients with a complete response using a different strategy, looking at immunoscore. So traditionally, immunoscore has, as one might surmise from the name, been to look at response to immunotherapy of different cancers. But this is a study showing that the immunoscore is also a biomarker for predicting the likelihood of a complete response to not immunotherapy, but chemoradiation and chemotherapy. So lots going on in this poster, a lot of cool details to look at. This was a multinational study, but the most important are these curves in this figure. You can show splitting between high, intermediate, and low, showing that there is really a difference in recurrence rates and response rates based on the immunoscore. So a little bit of a different flavor, but this was looking at, this was a study looking at the role of brachytherapy in inducing a complete response. So there has been a lot of interest in watch and wait. As you can tell from the OPRA study, 1/2 to 2/3 of patients achieve a complete response. So there are many strategies to think, hey, how can we increase the proportion of patients who achieve a complete response via a combination of local or systemic therapies? So this is using brachytherapy, the OPERA trial, not be confused with the OPRA study, seeing if using brachytherapy to dose escalate can result in a higher rate of complete response. So one thing to note, if you look at the eligibility criteria, these were smaller tumors. T2 to T3A to B and less than 5 cm in diameter, because those are more amenable to brachytherapy. And the study showed that, this was a randomized study, that the addition of brachytherapy, allowing for a higher radiation dose, did lead to a higher rate of organ preservation, which was actually 92%. Clinical complete response was 92%, which is very high. Again, these are patients with smaller, earlier stage tumors. Another study, this was a multi-center phase 2 trial, single arm, looking to see if we can escalate the radiation dose not through brachytherapy, but through external beam radiation. So these patients were treated to a total of 62 gray to the tumor and 50.4 gray to the regional node. So our standard radiation dose is about 50 to 54 gray to the tumor. So this is about a 10 gray dose escalation as compared to the standard dose. 86% had a local complete response, dropped to 61% at 2 years follow-up, but suggested that this is a feasible approach, escalating the dose to 62 gray. Okay, and lastly, this other poster, again from ASCO in 2022, looked at the addition of immunotherapy after chemoradiation rectal cancer. So a lot of excitement about immunotherapy, as I'll show a little bit on the next slide. Generally for rectal cancers, this is mostly seen to be efficacious, very efficacious in mismatch repair deficient rectal cancers. In mismatch repair proficient rectal and colon cancers, this has not shown to be helpful. The question is whether if we add it after or with radiation, can the radiation potentially stimulate the immune system to respond to immunotherapy? So this was a study of about 50 patients that received chemoradiation, durvalumab, and it showed about a third had a complete response. So not a randomized trial, so hard to know what the response would have been without immunotherapy. And there are other randomized trials ongoing, completed, that should answer this question or help to answer this question. All right, so just quickly on this very important ongoing randomized trial. So I don't talk about here because it's not directly related to radiation, but from Memorial Sloan Kettering published a study in New England Journal showing that mismatch repair deficient locally advanced rectal cancers in their study of about, I believe, 14 patients had a 100% response rate to immunotherapy alone, dostarlimab. So the question is, for those patients, what is the right treatment? This is a study for that type of tumor where the patients start with immunotherapy, and then the study has been amended so that if they have a complete response, they go to watch and wait. And if not, they go on to short course radiation and then surgery. So it's actually a small study, 31 patients, because the patient population is not very common, but I look forward to the results of the study and look forward to hopefully enrolling on the study. Moving on to pancreas cancer. So this trial was presented at ASCO in 2022. I don't believe the publication has come out. This is a CONCO 007 trial. So this is a trial of patients with locally advanced pancreatic cancer. They're randomized to start with chemotherapy, then either continue chemotherapy or get chemoradiation with gemcitabine. Initially, the primary endpoint was overall survival. However, due to slow accrual, the target accrual was very high at 830 patients. The endpoint was changed to R0 resection rate. Patient characteristics are here. One can also see that toxicities were higher with the addition of radiation, particularly leukopenia, thrombopenia, and total grade 3 and grade 4 toxicities. So we see that with the addition of chemoradiation, the pathologic outcomes are better, as shown in the table here, both PCR rates, R0 resection rates, and negative margin rates. This is what one would expect and has been shown in other studies as well. Overall, there was no difference in PFS and OS by the median numbers between the two arms. However, if you look at OS, you can see that the 5-year OS for all comers was 4.3% in patients receiving chemotherapy and 9.6% in those receiving radiation. So even though the median OS was the same, 15 months, you can see that radiation does prolong the survival tail. Below, you see some subgroup analyses of patients who were resected. Obviously, these are the best of the locally advanced since they actually underwent resection. You can see that the 5-year OS was really a lot improved with the addition of chemoradiation. And actually in the FOLFIRINOX treated group, receiving the most intensive chemotherapy, the 5-year OS when treated with chemo and chemoradiation was 27%, which is pretty impressive. So the study conclusions are here. I think the next steps is what we're all focusing on, basically figuring out which subgroup of patients may benefit from chemotherapy and the addition of chemoradiation. We know it's not all comers, but how do we figure out who, when, and how to give chemoradiation or radiation via SBRT? Okay, so moving on to esophagus and gastric cancers, there weren't really any new major trials in these disease sites, certainly not changing ones related to radiation presented last year, but I'll go over some of the important trials in these two disease sites. So this is a NeoAegis trial. I don't know if I'm pronouncing that right, but a commonly asked question for esophagus and gastric cancers is, should we treat with FLOT, peri-op chemotherapy with FLOT, or should we do cross, preoperative chemoradiation, and then surgery? So it makes sense to do a trial comparing those FLOT versus cross treatment regimens. So this was a trial of clinical T2, T3, N0 to N3, N0 esophagus and G junction tumors. And they were randomized to chemotherapy initially of ECF, but then with publication of the FLOT4 study, got changed to FLOT or allowed FLOT versus cross. Primary endpoint of overall survival. 180 patients or so in each arm. And you can see that there is no statistically significant difference in survival between the two arms. So it really doesn't answer the question for all comers, which regimen is better. At GI ASCO here in just about a week, they are going to present, I believe, the primary endpoint. So maybe there'll be some subgroup analyses, some pre-stratified subgroups that may be able to tell us for specific subgroups what regimen may be more beneficial. But important study to do. I'm not surprised that all comers there is no difference. Definitely when thinking about one regimen versus the other, looking at the details of the tumor, the patient, the biology of the tumor, and what it looks like on scans. All right, last is on anal cancer. This is the incidence of anal cancer is rising. It's a rather understudied cancer. I think at GI ASCO, the number of abstracts on anal cancer is like in the single digits. Fortunately, there are two very important trials from the U.S. cooperative groups assessing treatment personalization in anal cancer that I'll show here. So first, these slides just show the standard of care for anal cancer per a phase 2 trial, RTOG 0529. For T2N0, it's 28 fraction, total dose of 50.4 gray. For T3 or node positive, it's 30 fractions, total dose of 54 gray. All right, so two important trials. The first is a randomized study for early stage anal cancers called the DECREASE trial. Here's background. Basically, for these early stage cancers, do they really need the same treatment as a locally advanced T3 node positive cancer? Can we de-escalate treatment while maintaining outcomes to improve their quality of life? So a randomized study, again, eligibility is early stage. It has to be less than 4 cm and node negative. And both radiation and chemotherapy is de-escalated in the study. The chemotherapy is 1 dose rather than 2 doses of mitomycin C. And the radiation is de-escalated to 41.4 gray for T2 tumors versus 36 gray for T1 tumors. versus the standard, which is 50.4 grades. So quite a bit of treatment de-escalation. I like that their co-primary endpoints of both disease control and anorectal health-related quality of life. The randomization is 1:2, so 2/3 of patients are getting treatment de-escalation. Last I heard, the study is enrolling well. So I think this will be a very important study, and hopefully we can de-escalate treatment to improve patients' quality of life. On the other end of the spectrum, we are looking at how we can escalate treatment and how we can potentially improve outcomes for patients who have more high-risk cancers. So this is patients with locally advanced high-risk anal cancer who finish definitive chemoradiation. Here, they're randomized to observation versus adjuvant nivolumab for 6 months. The total end target is 344. I believe this study has actually finished accrual, which is awesome. So hopefully we'll get some results in the next couple of years and see if and specifically which patients might benefit from the addition of adjuvant immunotherapy. So that is it. We are just about 20 minutes. Hopefully that all recorded right. But it was great to talk to you about updates in GI cancers from the radiation perspective. You can find me on Twitter below. Feel free to post any questions and have a great new year.
In this lecture, I will review 4 classic studies of esophageal cancer and interrupt the health-related quality of life data of different treatment modalities. This is my report list. First, I will briefly introduce the basic knowledge of health-related quality of life. Then, I will choose 4 representative studies on systemic treatment, definitive chemoradiotherapy, surgery with or without neoadjuvant therapy, as well as supportive care for interruption. Finally, I will summarize my views. What is quality of life? The quality of life group of EORTC believes that health-related quality of life covers physical, emotional, social, and congenital functions, as well as disease symptoms and side effects of treatment. Why should cancer clinical trial research focus on quality of life? This is because some studies face situations where patients may not benefit from traditional endpoints. However, there may be significant changes in health-related quality of life. The most widely used is the EORTC cycle, including the QLQ C30 score quality of life cycle and the QLQ OES 18 cycle for esophageal cancer. Well, after reviewing the basic knowledge, let's move to the first study of health-related quality of life in esophageal cancer, systematic therapy, Keynote 181. The Keynote 181 study compared the value of immunotherapy and chemotherapy in second-line treatment of advanced esophageal cancer. The study found that pembrolizumab extended the survival of patients with PD-L1 CPS higher than 10 compared with second-line chemotherapy. Regarding health-related quality of life data, there was no difference in global quality of life scores between the 2 groups at baseline and week 9. The functional and symptom scores of QLQ-C30 and QLQ-OES-18 in the 2 groups remained stable from baseline to the 9th week. All EORTC QLQ-C30 function and symptom cycles in the 2 treatment groups decreased from baseline, except esomania. In EORTC QLQ-OES-18, it was observed that the symptoms of choked with swelling and dysphagia of patients in the pembrolizumab treatment group were improved, and the symptom of choked with swelling, reflux, and trouble swallowing saliva of patients in the treatment group were improved. In squamous cell carcinoma, EORTC QAQC30 overall health score improved in more than 20% of patients at week 9 and deteriorated in more than 30% of the patients. The progression time of pain, reflux, and dysphagia in EORTC QAQ OS18 was statistically similar, but the patients receiving chemotherapy had a longer progression time of these symptoms. Let's have a brief summary. Health-related quality of life of patients with advanced esophageal cancer decreased after systematic treatment and gradually recovered in 9th week after treatment. Similar health-related quality of life results were observed in patients with advanced esophageal squamous cell carcinoma treated with pembrolizumab immunotherapy and second-line chemotherapy. For interpretation, health-related quality of life of definitive chemoradiotherapy for locally advanced esophageal cancer, I will discuss the British Scope 1 study. Scope 1 was an iconic study of esophageal cancer targeted therapies. The research results showed that concurrent definitive chemoradiotherapy plus cetuximab for esophageal cancer does not improve survival but will increase toxicity. The results of the study cast a shadow on research on targeted therapy for esophageal cancer. Let's move to the quality of life data. It was observed that scores of health-related quality of life decreased during and after treatment compared to baseline scores in both treatment groups. The lowest score is often at 13th week to recover in about 6 months. For more specific symptoms, for severe eating restriction, severe appetite loss, severe fatigue, severe dysphagia, with the progress of treatment, it reaches the peak in 13th week and recovers in about 6 months. There was no difference between the two groups in these symptoms. This is a result of the 13th week. It can be seen that most indicators of patient's quality of life have deteriorated, except for cough at that time. And 104 weeks after treatment, that is about 2 years, the serious symptoms occurred during the treatment were alleviated. Let's have a brief summary of health-related quality of life in definitive chemoradiotherapy. Health-related quality of life was reduced during definitive chemoradiation in patients with locally advanced esophageal cancer. Health-related quality of life can be recovered and maintained about 6 months after definitive chemoradiotherapy. For studies related to surgery for esophageal cancer, the Netherlands cross study comparing the efficiency and toxicity of surgery alone with surgery after neoadjuvant chemoradiation cannot be missed. The quality of life results were analyzed. Generally, there is no statistical difference in health-related quality of life between the treatment groups after surgery. In both treatment groups, quality of life decreased 3 months after surgery compared with baseline and then continued to improve gradually. Eating problems, global quality of life, and emotional problems returned to baseline levels after follow-up, while physical function and fatigue remained impaired 1 year post-surgery. After about 8 years of median follow-up, no statistical difference was found between the two groups in terms of health-related quality of life endpoints. Compared with the short-term results of 1 year after surgery, the eating problem, physical function, global quality of life, and fatigue of the two groups of patients remained at the same level. Compared with that before treatment, the eating problem was better during the long-term follow-up, while the physical function and fatigue of the two groups did not return to the level before treatment. Let's have a brief summary. Health-related quality of life was reduced during neoadjuvant chemoradiation in patients with locally advanced esophageal cancer. health-related quality of life was decreased 3 months after surgery and recovered 6 months after surgery. Long-term health-related quality of life after surgery is similar to that about 1 year after surgery. Doubt-related problems are improved while fatigue and physical function are not up to pre-treatment. Last but not least, let's move to the supportive care. We have a phase 3 study from China. The authors established an interdisciplinary supportive care team of oncology, nutrition, and psychology. The phase 3 trial compares a combination of early nutrition and psychology intervention with first-line standard treatment with standard treatment. In the experiment group, they completed the assessment of nutrition status, psychology status, and quality of life before chemotherapy, and formulated individualized nutrition and psychological support treatment plans. The primary endpoint was overall survival, and the second endpoint includes quality of life scores, objective rate, and adverse reactions. The median survival in the early multidisciplinary treatment group was significantly longer than that in the standard treatment group. The quality of life scores of the two groups are baseline and week 9 are showing in the current figure. The emotional function and cognitive function were significantly improved 6 weeks after early multidisciplinary supportive intervention. Let's look at the nutritional and psychological assessment results. The nutritional and psychological evaluation of the intervention group was significantly improved 6 weeks after treatment. Let's have a brief summary. Early nutrition and psychological support combined with standard first-line chemotherapy can significantly prolong the survival time of patients with advanced esophageal cancer compared with chemotherapy alone. Okay, let's move to my final conclusion. First, systematic and local therapy will impact the health-related quality of life in patients with esophageal cancer during and after treatment. Second, health-related quality of life may recover in 2 to 3 months after systematic treatment and 3 to 6 months after local treatment. Third, early supportive care by a multidisciplinary team of oncology, nutrition, and psychology can improve health-related quality of life and survival of esophageal cancer very effectively. Also, I will also add my personal opinion. We'll say that we should make cancer patients live longer and better. Therefore, we are constantly developing new drugs and technologies. All the exploring and development is very good and exciting, but when we look back, the most basic, early, and timely support for human needs of nutrition and emotion significantly improve the survival and quality of life of patients. Thank you.
Hello, I'm Grant Williams, Dr. Williams. I'm a geriatrician and medical oncologist here at the University of Alabama at Birmingham. And today, as part of the OncoAlert 2022 series, I'll be talking about integrated geriatric assessment into the routine care of older adults with cancer. A little bit on the agenda here. I was going to start out with an overview of the field of geriatric oncology and then examine strategies to assess older adults with cancer. We were going to look at the barriers and the role of geriatric assessment in the management of older adults with cancer. And lastly, specific to some of the practice we do here, describe our implementation approach to how we integrate geriatric assessment and routine practice. So you can see here are some of the age-specific cancer incidence rates in the United States, recently from SEER. And I think what quickly becomes apparent is that it's not until really the 4th, 5th, or 6th decade of life that we start to see pretty significant increases in the incidence rates, really peaking in the 8th decade of life. Cancer is the largest risk factor for the development of cancer, and you can see here that the incidence rates are strongly associated with increasing age. Already in the United States, the median age at a cancer diagnosis is 67. Looking at shifting demographics over the coming years into 2030 and to 2040, up to 70% of all new cancer diagnoses by 2040 will be in those over the age of 65. And I think when we really look at the change in that growth, we'll see a 44% increased growth of those over the age of 65. But even more importantly, it's going to be those in those older age categories, like over 85. We're going to see 115% growth by 2040 in those over the age of 85 developing a cancer. And when we really look at those cancer survivors, those that have kind of developed cancer, had treatments, or have ongoing treatments, already a lot of these are older adults as well. And fast forward in the next coming years, 2030 to 2040, the vast majority of cancer survivors will also be in older adults. So you may ask yourself, why does that matter, right? We treat all cancers the same based on cancer stage and type of the molecular profile. But I think it's helpful really to think about the aging process itself, which is very heterogeneous. So unlike the developing process, which is very linear with these very set milestones, the aging process is very heterogeneous, whether that's from environmental factors, genetic factors. The pace at which we age is very unique. Now, we may not notice this difference in the pace of aging in those in their, say, third, fourth, or fifth decade of life, but many of us recognize that when you get in the sixth, seventh, and eighth decade of life, that we can see individuals of the same chronological age that may look very different. And for example, here we have an 80-year-old that is highly functional, has no significant comorbid conditions, doesn't take any regular medications, and could be doing such things as, barefoot water skiing on the weekends. But we can have others of the exact same chronological age that have severe functional impairments, such as being in a wheelchair here, maybe significant comorbid conditions like heart failure, COPD, and that are just truly very limited. Now, these two examples very much represent the ends of a spectrum. And if every patient that walked in the clinic fit in one of these two categories neatly, this wouldn't be much of a challenge. But, these are really the ends of this large spectrum that we see amongst older adults. And it's very clear that chronological age alone is very insufficient. So when older adults are diagnosed and undergo treatment for cancer, their outcomes are highly variable. We know some older adults have similar benefits to these treatments, whether surgery, radiation, or chemo, as their younger counterparts. And they're going to be able to tolerate things quite well, whereas others may be at an increased risk of adverse events, may poorly tolerate treatment, and are really at risk of overtreatment more than anything. So how do we understand, who's going to do well and who may not? So really your health status at the time of a cancer diagnosis is probably one of the most predictive things of cancer outcomes. So that begs the question of how do we assess older adults with cancer? And this really remains a large clinical challenge amongst the field of oncology. What we do know is chronological age and performance status, which is a crude measure of function, alone really insufficient. And a lot of the field of geriatric oncology has really searched for better ways to assess older adults, particularly systematically and using validated measures. So this question of, how are older adults evaluated in oncology practice was one of the things that was asked in a recent ASCO survey that was answered by over 1,000 oncology providers. And one of the things was, do you assess older patients different than your younger patients? And it was quite overwhelming that most oncology providers, either some, most, or always, assess their older adults different than their younger patients. But when asked, in what ways do you assess these patients differently, it appeared that the majority, 70%, really were using these informal assessments, or some people like to think of like an eyeball test, whereas only about 29%, or a little under a third, were using these more formal objective assessments. Now, when we think of these assessments, I like to think of this term of the geriatric oncology iceberg, where, we usually have our standard oncology assessments, such as age, performance status, tumor characteristics, such as cancer stage, the mutation, characteristics. And lastly, we really want to know about organ function, right? We all want to get a CBC, take a look at the hemoglobin, platelets, immune system, creatinine, liver function, all of these things that we know we have to check to be able to safely deliver any sort of cancer treatment. But really, I would argue that for older adults with cancer, this is really the tip of the iceberg. And it's really what's under the surface that is critical to making individualized and tailorized plans for older adults. That's polypharmacy and comorbidities, falls, psychosocial dysfunction, functional and cognitive impairments, nutritional deficits, sarcopenia, and social support. These are really critical aspects to developing cancer treatment plans, and are really what are the domains that are primarily included in something we call a geriatric assessment. So what is a geriatric assessment? So it's a systematic, validated approach to identify strengths and to treat vulnerabilities of older adults. And in this situation, we're talking about cancer. And you can see here on the figure on the right, it really is all those elements that are underneath the iceberg that this assesses. And it does it in a systematically validated way. One of the challenges is that, typical geriatric assessments, which are performed by a geriatrician and a multidisciplinary team, requires lots of time, specialized personnel, and expertise. And when we looked at, particularly in the United States, what is the availability to do co-management of cancer patients with a geriatrician? And back in 2020, as part of the NCORE, the NCI Community Oncology Research Program, their network of community oncology sites, we actually did a survey looking at the availability of geriatric specialty care. And first we asked, what is the availability of geriatric oncology dually trained providers at sites across these community sites across the US? And it was very low. So only 2% reported having access to a dually board certified geriatric oncologist. More to the point, we asked about what is the availability of a geriatrician for consultation or co-management at the site. And about a third of sites said they had some access to a geriatrician. But when we drilled that down and looked at, how do they have access? Only 13% had access within the oncology clinic. 54% had it more available as an inpatient consultation, so within the hospital. And the majority had availability out for consultation external to the oncology practice. So this is another geriatric practice in town or in the region that they can access. So when we really look at those, how many had available within the oncology clinic, it was really 5% of the sites overall had easy availability within the actual oncology clinic. So I'd argue that, looking at ways to, rely upon the geriatrics workforce to really evaluate these domains, unfortunately, is going to leave most patients and providers without much help. And this was really early recognized in the field of geriatric oncology that there weren't going to be enough, nor a timely enough consultation with geriatricians for all of these needs. And Arthi Huria, who clearly was a seminal leader in the field, whose life was unfortunately cut too short tragically, really did a lot of seminal work here around how can we do a brief geriatric assessment or a simplified geriatric assessment in routine oncology care. And what she did is developed what has now become known as the Cancer and Aging Research Group, or CARG geriatric assessment. And it really broke down these domains, these things under the iceberg, and broke them down into kind of two different groups, those that needed to be done by the healthcare provider and those that could be completed by the patient alone. And by doing this, it really shortened the geriatric assessment to under 30 minutes. And the bulk of this was being done just by the patient. So it could be answered in the waiting room or at, prior to the visit, and really got this down to be, a functional, relatively simplified tool. Now, why should we do a geriatric assessment in oncology? And I think, the literature has been growing and growing over this over the last few decades. The first thing that was clearly shown is that it uncovers problems not routinely found. So we know things like falls, lack of social support, malnutrition, functional impairments. These are all things that are really important and, strong predictors of outcomes, yet are not routinely evaluated within the usual oncology assessments. It can improve life expectancy estimates. So a lot of this information is prognostic of survival. It's also predictive of treatment-related toxicities and other outcomes, such as hospitalization, long-term care placement. It has been shown that using a geriatric assessment as part of management can improve communication and quality of life of patients. And more recently, it reduces the incidence of severe chemotherapy toxicities. And I'll talk about some of these more recent studies here at the end that really serve as the evidence base for doing these assessments in oncology. So, and thinking of a very simplified way of using this information, I just wanted to kind of discuss a few different scenarios of how you can use a geriatric assessment to kind of stage the aging. So one thing after you complete a geriatric assessment is you can find fit individuals that really have no functional impairments, no significant comorbid conditions or geriatric syndromes. And, these are the patients that are at most at risk of undertreatment. So I think these are the patients that should get a green light, can really go on with their standard oncology treatment. Whereas on the flip side, we have those patients that are frail or have some dependence in an activity of daily living, such as bathing or transferring. They may have several comorbid conditions or even just one that's life-threatening, such as COPD or heart failure, or have the presence of a clinically significant geriatric syndrome. So these are patients that, really are more at risk of overtreatment and would very likely poorly tolerate either chemotherapy or surgery and may benefit most from a more palliative approach with focus on comfort, depending on the situation. But I would really use extreme caution in this patient population. And really there's an intermediate group or a vulnerable group. And these are patients that may have some dependence in instrumental activities of daily living, but not an activity of daily living. So they need some help with housework or cooking and cleaning, or handling money or medications, but they can do those really core things such as bathing and transferring. They can have some comorbid conditions, but none that are either severe or life-threatening, and no significant geriatric syndromes. And really this is where the more challenging group and frankly, in a lot of cancer populations, the largest group. Now, when we think about how you use this information, I like to think of it simply in two different buckets. One is you can get this overall fitness assessment. Are they fit? Are they frail? Are they pre-fail or vulnerable? And this can really help tailor your cancer treatment plan. As a medical oncologist, this may help me decide, do we do 3 chemotherapy drugs like a FOLFIRINOX, or should we just do 2, such as FOLFOX, or maybe even simply just 5-FU alone? And you can modify the frequency. Do you do Gemabraxane 3 weeks in a row, 1 week off, or do you do every other week? So you can really change your cancer treatment, either the agents, maybe consider an upfront dose reduction. These are things that we can modify our actual cancer treatments based on these identified vulnerabilities. And then secondly, I like to think of slightly different is, a lot of these deficits or impairments that we identified actually have known targeted treatments. For example, if someone's malnourished and has lost significant weight in the last several months, seeing a nutritionist, getting a handout on, high calorie foods that they can eat can be very beneficial. Similarly, if someone has falls or functional impairments, getting them to a cancer rehab program, potentially physical and occupational therapy, can greatly be helpful. And we're seeing that more and more of these interventions can be beneficial in cancer populations. Really, ASCO 2020 was a banner year for a lot of geriatric oncology, where we actually had 4 randomized controlled trials, 2 of which really focused on chemotherapy toxicities. One was more around quality of life and hospitalizations, and another in the setting of surgery and looking at length of stay and postoperative ICU use. And really was a turning point in the field of geriatric oncology, where we really started to have this randomized control level, very high level evidence to show how a geriatric assessment can be utilized to improve management. And I wanted to point out a few of the seminal work here, particularly the GAP70 study, which was a cluster randomized controlled trial that showed that geriatric assessment with management actually reduced the odds of severe chemotherapy toxicities, both overall and particularly for the non-hematologic toxicities. And this was done by Dr. Mohile, and it was published in Lancet just last year in 2021. And then really thinking about those guided interventions, this shows each domain, what a deficit would look like, and in potential interventions. This is actually from the GAINS study published in JAMA Oncology, also from last year. And I think it really helps just kind of give you that global picture of the different interventions we could be talking about. So I think you've heard a lot of information about this. And hopefully everyone in the country is doing a geriatric assessment, as this is recommended by the International Society of Geriatric Oncology, ASCO, and NCCN guidelines. But as part of that ASCO survey of oncology providers, we also asked, how often are you performing a geriatric assessment as part of management? And unfortunately, about 80% are either never, rarely, or only some of the times doing a geriatric assessment. And we really tried to drill down on, what are the barriers and why are people not performing geriatric assessment? And it really seemed that lack of time, support staff, training, and uncertainty and lack of awareness of tools were really those key aspects that were really the biggest barriers to performing geriatric assessment. And when we looked at, who's aware of the geriatric assessment ASCO guidelines versus who is not, and to me, this is telling me, who's more aware of the field and potentially the benefits of geriatric assessment versus who is not, we kind of found two distinct patterns. One is those that are aware of the ASCO guidelines and theoretically maybe more aware of the benefits of a geriatric assessment. It's really this lack of time and lack of support staff that are really the preeminent barriers to performing this. Whereas the others that were unaware of the guidelines, it was really this lack of training and knowledge, lack of awareness of tools and uncertainty of which tools to use that were really some of the top barriers to performing geriatric assessment. And I think this is critically important when we think about, how can we overcome these barriers? There may be different solutions for these two different groups. Importantly, I'd like to point out, we asked, was it limited evidence to support the use that was a barrier? And this was actually the least barrier that was found in this survey. And this is actually before, the survey was before we did, we've seen a lot of the higher evidence trials that have come out more recent. So I wanted to shift a little bit to talk about, what are we doing here at the University of Alabama, Birmingham to implement geriatric assessment? And one thing we developed here is something called the Cancer and Aging Resilience Evaluation, or the CARE tool. Now, this is something very similar to the CARG geriatric assessment, is actually based on that tool, but has been converted to be 100% patient reported. So we got rid of the timed up and go and the blessed orientation, memory, concentration, cognitive tests, and instead relied 100% on patient report to really assess these different domains and impairments. And what that did was really able to cut our time down from that 20 to 30 minutes down to just 10 minutes. A big time saver is we no longer ask patients, to write down the whole list of medications and just instead tell us how many medications they take on a daily basis. And we're still able to really detect a lot of the similar prevalence of impairments as what we've seen in the literature. So we're still identifying these needs and impairments. We started this out actually just as a paper questionnaire. So over the age of 60, and you're checking in as a new patient, we simply handed them a survey that really touched on all these different domains that we talked about. More recently, this has started to shift. So this is some of our work over the last 5 years of recruiting and completing these surveys. We've got over 2,000 patients to date that have completed this survey, which was initially done on paper, but more recently we have converted to an electronic cancer and aging resilience evaluation, or what we now call WeCare or web-enabled. And we've now learned that we can integrate this in directly into the EMR. So this is an example patient where you can actually see a little bit of the display that we're showing patient to providers as part of routine care. And I did want to break down, what is it that's in these reports that we try to give to feedback to providers. So the first is this, high level forest view of that red light, green light, maybe yellow light, and to understand their, frailty overall. So, 3 categories: robust, pre-frail, and frail. And this is all scored by a deficit accumulation method and using a frailty index from the whole survey. And here, this gives you that high level impression as to how a patient's overall doing with their actual score underneath and the number of domain impairments we found. So I think this is the part that is, from an oncology provider standpoint, the most helpful in really developing those and tailoring the treatment plan. Do we do FOLFIRINOX? Do we not? Do we do single agent versus reduced upfront dosing? This is that key information for the oncology provider. And then secondly, we really want to focus on those interventions we talked about. Like someone has functional status impairments, we really want them to get their actual interventions that are needed and shown to be beneficial. So, here, if you click those 3 dots and the more, you can actually see the full recommendation. Which here is, functional impairment is very strongly tied to, chemotherapy toxicity. So we actually consider a dose modification up front here, consider more frequent toxicity checks similarly as part of that. And then really this PT and OT or cancer rehab approach. Similarly for nutrition, this is really focusing on considering a nutritionist or dietitian referral, maybe a dentist and checking dentition, speech referral, Meals on Wheels, really focusing on the antiemetic regimen here, but really things around nutrition. Now, these are actually taken and adapted from the GAP70 study. So these interventions are really what was in that Lancet Oncology publication that we talked about earlier. So really conclusions, I hope that I've convinced you that older adults really may require special consideration during decision-making for cancer treatment, and that a geriatric assessment can really aid in this process in two ways. One, it can really help with risk prediction, whether it's survival, chemotherapy, toxicities, and that this can really dovetail in helping us develop and personalize our treatment plans. But then also that you can use this information to guide interventions that may meaningfully improve cancer treatment outcomes. And I think I've been able to hopefully show you that a pragmatic or a practical geriatric assessment can be integrated into clinical care. And this really has two goals in my mind. One is, we're trying to improve and personalize the care of older patients. But another thing, which we didn't discuss as much, is that this really can also result in an annotated large database and can hopefully answer future questions in the field and expand our knowledge in geriatric oncology. So putting it all together when managing older adults, it's really looking at the likelihood of benefit with these treatments and examining the likelihood of harm and really integrating this in with the values and preferences of that patient. So this is really the fulcrum of which we help make these decisions and guide interventions. So I'd just like to acknowledge UAB and the Institute of Cancer Outcomes and Survivorships here, and as well as my mentors, co-investigators and collaborators, and some funding from NCI and the American Cancer Society. And I will go ahead and stop there. Thank you for the opportunity to talk about this important project. And feel free to find me on Twitter if you have any questions or want to have any additional follow-up. Thanks so much.
Dear colleagues, thank you very much for joining us today for this day 5. And please join us tomorrow when we'll be covering the EON session, along with cancer and COVID and the importance of oncology education from ESO. Great presenters like the EON's president-elect, Dr. Solisari, oncology nurses Van Klinken and Dodlik, Drs. Inu, Alsendi, and of course, our amazing OncoAlert colleague, Dr. Kuder. We look forward to seeing you tomorrow, and thank you for your attention. Until then, thank you for sharing this colloquium, and thank you for being OncoAlert.